And let's assume now we have a patient with what we call curative intent. And at least I hear about surgery and transplant and who's who.
That's right. So every single surgical conference that I've ever attended had a session on should we transplant or should we do a resection? And the reality of the situation is you're talking maybe about 1 or 2% of the patients that you see. And I think it depends on where you live. If you live in a region where you can get a transplant fairly quickly within the first couple months of being listed, then I think probably that most centers will vary or have a bias toward transplantation. I know in New York and in our centers down in Texas, we're transplanting at around a MELD of 30-ish.
Let's tell our oncologists what's a MELD.
So a MELD is a combination of bilirubin, INR, and creatinine. And typically it's the measure to determine transplantation in patients who don't have HCC or just chronic liver disease. If you have HCC and you meet a certain criteria of size above 2 centimeters or so, then you get an exception points of 22, and then every couple months you get an additional 3 points. At our center, our bias is to resect everybody with these solitary lesions, and I think it's because when they went to the MELD exception points in 2005, what we're seeing now is we're seeing such a preponderance of patients on the waiting list with HCC that patients with chronic liver disease are not really being able to afford it for a transplant. Organs are in such a paucity that I think most centers will vary as far as doing a resection on those patients. And I'm not sure what it is in your guys' centers as well.
So just to summarize that component again and make sure that we define, other than the debate, which you're right is kind of like ongoing, but if I hear you right, if the lesion is potentially resectable, you proceed with surgery, and this way you're almost like resetting the clock while there's potential. If there is a recurrence, this is when you go in and put on the list for transplant.
That's right.
And the criteria that at least we use at our center are pretty much the Mazzaferro or the Milan criteria, which historically have been reported by the group in Milan, where they found that if you follow those rather rigid or strict criteria, the chance of cure or to be free of any recurrence for 5 years bypasses 75% are 1 lesion less than 5 centimeter, 3 lesions, each one of them less than 1 centimeter, and no vascular invasion and no metastases. And obviously that envelope can expand and shrink as deemed by certain institution. What do you feel about it? Would you expand it, limit it?
For transplant, we use more of kind of, and I think most centers use more of an expanded criteria by the UCSF criteria. And I think because the whole, you have to remember, I think is the funny thing about the whole Mazzaferro study was it was based on essentially 40 or 50 patients, and it essentially changed transplantation and how we allocate organs. But I think they probably brought it down to a level that was too strict. And I think most centers in most regions are using the UCSF expanded criteria like we are. As far as for surgical resection, essentially for us, as long as we are starting to delve, and it's very controversial, but we're starting to delve into resecting more multifocal disease. Just because of some of the data by Ronnie Poon's group, albeit in Hep B patients, they've shown that it's actually probably a little bit better than treating with local regional therapy alone, provided that the patients don't have any underlying portal hypertension. So we check the platelet count of 100. If the platelet count's over 100 and we feel that we can leave enough liver remnant behind, usually we're aiming for about 40% to 50%. Then we'll offer them a curative resection.
But do you do wedge or do you do lobectomies?
Well, I mean, that's also controversial too, is this idea of whether you should do a wedge resection or non-anatomical versus anatomical. And it's a little bit different, I think, than colorectal liver metastasis, because there's this thinking with HCC because that there's this vascular invasion. We aim to achieve a negative margin by about 1 centimeter, and it can become a little bit difficult with these kind of lesions in the center, segment 8, segment 5, right in the center of the right lobe. And in that case, depending on the patient's comorbidities, we might turn them over to you for ablative therapies.
Yes. So that's
Richard.
an interesting concept, but the thing not to forget is that this is a field defect, right? And the analogy I like to use with patients in describing it is it's a garden that has weeds, and you might pull out a few weeds, but you leave behind bad soil. And so that always comes back again to transplant and the attractiveness given the utility of how we use those organs, but the idea that we can replace the sick liver, and now with the hepatitis C drugs, prevent recurrence, or with hepatitis B, prevent recurrence, and take out that risk of recurrent cancer with properly selected patients by giving them a fresh organ.
I can see already that the concept of transplant and surgery is beyond only the realm of a transplant conference. And you're right, it's all the conferences are about like the criteria and who you transplant. But let me ask a question, and this is where we're going to start a little bit of that discussion as a multidisciplinary team at the tumor board, because we just heard about radiofrequency ablation as a curative therapy. So, Jeff.
Yeah, I mean, it's considered curative, and in fact, the guidelines support that concept. The data is pretty convincing that every single time a study was conducted comparing RFA to surgical resection, the ability to kill the tumor is about the same. The only difference is really in the recurrence, and the survival is about the same, but the recurrence is much higher with RF ablation than it is with surgical resection. Could be margins, it could be what you talked about, angiogenesis, you know, this whole notion. But the fact is that if you think about the ability to kill the tumor, RFA is about equivalent to that of surgical resection. But my question, to go back to the issue of transplant versus resection, is that in our place, for example, we've always promoted transplantation as opposed to resection. So if we can get a patient to transplant, that is always the goal. And we have means to do that, to keep patients on the transplant list, keep them, you know, waiting essentially, so that they don't fall off the transplant list and lose the chance of being cured, because the only cure is transplantation.
Something, I can make one comment on this, and that is that in September, approximately, the rules for liver cancer organ distribution are going to change dramatically. Two things. There's going to be a cap, a MELD of 34. You won't be able to get above 34 to get access to organs. And for the first 6 months you're on the list, you don't get any extra points. You don't actually start getting points until you're on the list with the cancer for 6 months. So people will fall off probably because of aggressive disease. This is going to be instituted simultaneously with UNOS, and all this is going to change. And the sad news is we have 35,000 liver cancers and 6,000 livers. Something has to give with a 20 to 25% death rate on the wait list. There's a lot of dynamics here.
And I think this is a very important and a critical component of the discussion, as much as it might be perceived as an academic discussion and what do we favor in regard to the bad soil theory that we heard from Dr. Finn, from the practical point of resecting what's at hand and not to wait for the list. But realistically speaking, exactly, this is a major issue nationally about, like, you know, organ distribution and organ availability for the patients with HCC. In a way, on the positive side, this is a problem that only challenges a few patients, but sadly, we wish it challenges more patients, because unfortunately, patients do present with more advanced disease, and it's